right, I think we're ready to go.
Okay. Thanks for coming, guys. This is the cardiorenal syndrome. Most of you have been over this with me once or twice, and I want to use today to consolidate where we are in 2023. There's some new information that I think is helpful. And so, as an introduction, I don't want to start with the classification. The classification is very complicated. It starts heart first, kidney second, acute heart, acute kidney, chronic kidney. That's really not what I want to get into today. Kind of what I want to deal is the kidney side of it. There has been a ton of new outpatient heart failure data, especially in preserved ejection fraction heart failure, whether it's Entresto, SGLT2 inhibitors, MRAs, in heart failure with preserved ejection fraction. They're all very exciting new additions to the cardiologist armamentarium. All protect. The SGLT2s may be a bit better. We're not sure if they're additive yet. And the other aspect of this, again, outpatient-wise, is that there's now data that SGLT2 are adjuncts to diuretic therapy to help with diuresis on the outpatient side. What I want to do today is I want to do the heart first, bad heart, and secondary kidney. I don't want us to forget about the importance of afterload reduction. That's been an issue a couple times in the last month at Denver Health. We've had to fight with cardiology about that, believe it or not. And the real deal today is the discussion of diuretic therapy. So a one-liner on the pathophysiology of reduced ejection fraction heart failure. Because of the reduced cardiac output, there's baroreceptor activation, whether in the lungs, right side, or the heart, left side. So there's a storm of catechols, alpha and beta receptors, Ang2 and aldo, vasopressin, and the new player on the block is endothelin. We don't have studies yet on the role of endothelin receptor antagonists in heart failure, but they're coming soon. The downside is the potential for salt and water retention, and so it'll be interesting to see how it goes. In any case, because of baroreceptor activation, there's an increase in both systemic and renal vascular resistance, salt and water retention, and that's where we're going to go today. The question that always comes up is, what about venous congestion, abdominal venous congestion, especially in the liver? And so the data in left-sided heart failure is not particularly convincing. The data for right-sided heart failure, especially in an acute setting, like you'll see later on in one of the cases, or in the setting of liver dysfunction, it's more convincing. Not so much today do I want to deal with it. Any questions so far? Okay, and so I want to go on to the diuretic side of things. And so you've heard me do this 101, this many, many times before. The importance of renal 101, what you eat or what the intern gives you, got to come out in the urine or something bad is going to happen. And so today I want to deal with the spot urine sodium and urine potassium, which for the first time we actually have data for that I'll show you. And I want to remind us of the limitations. A couple comments on PO versus IV diuretics. No comments on differences between furosemide, bumetanide, and torsemide. Bottom line, no difference in outcome. Couple studies in 2023 comparing furosemide, torsemide on outcome, and not surprising to us, not much of a difference. For today, I want to assume the albumin is normal, another talk, and a few comments on bolus versus infusion injections. And so the first study I want to show you was published very recently in JACC, entitled Natriuretic Response to Acetazolamide in Patients with Acute Heart Failure and Volume Overload. And so the background for this goes as follows. Acetazolamide facilitates natriuresis and decreases hospital stays in acute heart failure. I'll show you that in just a second. However, the relationship between natriuresis and acetazolamide is unclear. IDIE doesn't mean anything if you have more or less natriuresis. The methods go as follows. It's a secondary review of the so-called ADVOR study, acetazolamide in decompensated heart failure with volume overload, that was published last year in the New England Journal. And kind of for this particular study, the issue is, what are the predictors of natriuresis and the relationship of urine sodium, and that's key to me, to volume overload at 3 days after hospitalization? And so here is some of the data. This is the indication that higher 24-hour urine sodium is associated with more rapid decongestion. And so if you look at the x-axis, it's the weighted urine sodium over 24 hours. And you can see, starting at a urine sodium of 20, as the urine sodium goes up to, in this study, 140, the hazard ratio improves dramatically. And so higher urine sodiums are associated with more rapid decongestion. This next slide is the moneyed slide from my perspective. This shows that a higher spot urine sodium is associated with better outcomes as well. First study ever looking at a spot urine sodium. If you look at the left side, it looks at the weighted urine sodium concentration in spot numbers, less than 50, 50 to 79, 80 to 99, over 100. And you can see that the higher the urine sodium, the more likelihood there is decongestion. If you look at the weighted time, 24-hour urine sodiums, they're also weighted as well. And so there's greater natriuresis, whether you use a spot urine sodium on the top or 24-hour urine sodium, negative urine sodium, are associated with fewer hospital days. This is a urine spot less than 50, over a urine spot less than 100. So the higher the spot urine sodium, fewer hospital days. The conclusions were, in acute heart failure, greater natriuresis associated with better outcomes. Urine sodium may be an attractive measure of effective natriuresis in future trials. This is the first time cardiology has recognized the importance of urine sodium. In fact, they've never talked about a spot urine sodium, but now they're suggesting that perhaps that may be the way to go in all patients requiring diuresis. And it goes to Renal 101, just to ice it again. You got to pee what you eat, or what the intern gives you, or something bad is going to happen. In the face of sodium, you blow up. In the face of potassium, you die. And we're going to come back to that theme a few more times. Now, I want to spend a slide or two on the pharmacokinetics and dynamics of loop diuretics. This is work that David Ellison, who now is OHSU, had been in Colorado for several years, has done through the years. A couple references at the end of the talk, his work, and these are the moneyed slides, I think. And so this is a New England Journal study from about 5 years ago. On the left, you can see the log of a diuretic dose, and on the y-axis, urinary sodium excretion. And the idea here is, if you look at a healthy person in the blue, there's this dose-response curve, exponential dose-response curve, with a ceiling effect, maximum diuresis up around here in patients with reduced ejection fraction heart failure. Sorry about that. With reduced ejection fraction heart failure, you can see the whole thing is pushed over to the right with a lower ceiling effect and less natriuresis given any dose of diuretics. If you look at the right side, it simply looks at the difference between intravenous and IV PO diuretics. You know this stuff. And so the idea is that intravenous diuretics in normal individuals work quickly and go away fairly quickly. Oral diuretics take longer to work, stick around for longer, etc. And so if you look at the difference between a normal person and someone with heart failure, it takes more of a dose of anything to see an effect on urine sodium excretion. And so this is something that you're aware of and you know about. The next slide is very important to me because we've dealt with this a couple times in the last couple of months at Denver Health. And I think with all due respect to the cardiologist, I'm not sure how much they recognize this. And this is known as the braking phenomena of diuretic use. And the fact that post-diuretic use, there actually is sodium chloride retention. So if you look over here to the green box, this is going to be a dose of diuretic at some point and urinary sodium excretion. And you can see that here's the first dose of diuretic and a big increase in urine sodium that degrades pretty quickly. And this kind of brownish area here is after the diuretic has gone away, there is net positive sodium retention when the diuretic goes away. And so if, for example, you were to use IV diuretics once a day, you can see you'd spend a few hours peeing sodium and the rest of the time retaining sodium. If you go with me for a second to the second dose, less of an effect, sodium retention. Third dose, less of an effect, sodium retention. You see where this is going. So if you were to do a spot urine sodium after this dose, it might be higher than this, and this. And so that take home here is you can't rely on a single urine sodium determination. You've got to do it a couple times to see where you are and make sure that the spot urine sodium is more than 60 to 80. I want to stop for a second and make sure people are comfortable with that.
Hey, Dr. Linas, one of the things that I feel like we don't do we don't give any thought to is the urinary volume. So
give me a second. Give me a second, okay?
Yeah.
I'll come back to that. Very, very important. That's going to be the limitation of the spot, and I'm going to show you in just a minute. All right. I want you to see this study. It's about 10 years old now, entitled Diuretic Strategies in Patients with Acute Decompensated Heart Failure, Bolus versus Continuous Infusion. That's something else near and dear to the cardiologist. So this is a double-blind, randomized, prospective trial. Acute decompensated heart failure, no funny business. And these are individuals given IV furosemide, bolus every 12 hours, which was their outpatient dose. For example, 160 milligrams BID, which is close to what they were taking. Continuous infusion at low dose, mean the patient's oral dose, i.e. 160 milligrams infused, or higher doses, 2.5 times the oral dose. So this works out to, if you do the arithmetic, either 13 milligrams per hour or 33 milligrams per hour. The primary endpoint was composite of symptoms and creatinine at 72 hours, near and dear to what we're interested in. And so a bit of a complex slide that I've entitled Global Assessment of Symptoms. And so there were no differences between infusion or high and low dose. And so you can barely see the difference between bolus and infusion here. And these are symptoms. And this is low dose and high dose that projects a little better. And so you can see, as far as symptomatic relief, no difference between bolus infusion or high and low dose. There tended to be a better GFR after continuous than high dose, but you can see none of this stuff is significant. Bottom line is that from a renal perspective, the kidney doesn't quite care whether it's bolus or infusion, low or high doses. If you looked at a composite endpoint, death, rehospitalization, ED visits, and a couple others, there really was absolutely no difference between continuous and bolus or kind of high dose or low dose. And so the conclusion from this study is when diuretics are administered as bolus or continuous infusion, low or high doses, there were no differences in symptoms, creatinine, death, rehospitalization. And so no reason to go to infusions as any advantage over bolus. One last point before looking at some cases, and that gets to the issue is how does reducing LV filling increase cardiac index? Now, you would think you're marching down the Starling curve by doing this, but in fact, there are other things that influence this, and you actually march up the Starling curve. The easiest thing to understand is what I call geometry, and it simply means that if you look at a failing heart, it'll at times, if it's really bad, can look like a balloon with ears on it and a whole bunch of things, and it doesn't contract normally. And so if you can get the volume down from an actin myosin perspective, et cetera, it can contract more effectively and increase cardiac output. And this will be a big issue when we start talking about the right-sided stuff. The other thing that I like immensely is something called the role of endocardial hypoperfusion. And so it goes as follows. The endocardium is perfused from the outside in, from the pericardial side to the inside in. So, for example, under normal circumstances, I'm just going to use diastolics now for a minute. If you have an end diastolic of 80, an LV end diastolic of 5, you have a delta of 75 and you perfuse the subendocardial areas. On the other hand, if in heart failure, let's say the systemic diastolic is still 80, the LV end diastolic now is up to 30, so the delta to perfuse the subendocardial area is 50, and there's less perfusion and reduced ejection fraction. If, on the other hand, you treat with a diuretic, the systemic diastolic may go down a little bit. The end diastolic, if you're lucky, can get it down to 10. You can see that the perfusion pressure for the subendocardial area goes up to about 60, and you improve cardiac index. Any questions about that? All right, and so I want to go through some patients, and this is a potpourri of what we get asked to see. And we'll take it one at a time. And so this goes as follows. My patient has new onset reduced ejection fraction, heart failure, not yet on any medications. The sodium is 126. The K is 5.7. The chloride is 97. The bicarbonate is 18. The BUN is 56. The creatinine 1.8, doubled from a year ago. And the acid base are 731, 35, and 18, both a metabolic and a respiratory acidosis. And so someone want to take a shot at explaining some of this kind of stuff in new onset untreated heart failure. So someone start with why are some patients with new onset heart failure actually hyper, not hypokalemic, despite all the renin and aldo.
No distal sodium delivery, so you can't exchange it and pee it out.
Right. I mean, it's pretty straight up. How about the metabolic acidosis?
Increased proximal reabsorption.
Same issue. If you don't deliver sodium to the cortical collecting tubule, not only can you not secrete K, you can't secrete proton, and you end up with a metabolic acidosis. The respiratory acidosis is bad chest x-ray, et cetera, et cetera. That's easy. How about the BUN to creatinine ratio?
Hypoperfusion.
Louder.
Hypoperfusion.
And what does that do? So urea is obviously it's different than creatinine, and in essence, in very kind of hypoperfused states for any reason, heart failure, pre-renal, etc., then urea can be reabsorbed in contrast to creatinine. So it's pretty classic that you see ratios like that. And the hyponatremia is straight up. You're not perfusing the baroreceptor, and so you end up with not only salt retention, but water retention. And so untreated heart failure, looks like this. My patient with heart failure responds well to loop diuretics, but is gaining weight in the hospital. The urine sodium is 35 on a spot, and this gets to the question. The 24-hour volume is 4 liters. The 24-hour urine sodium is 140. And so the principle here is to remind me, as you already have, to remind you of the limitations of the spot urine sodium. And the major limitation of the spot urine sodium is you got to have some handle on what the 24-hour urine is. If the 24-hour urine were 100 cc's, a spot of 35 is pretty low. The 24-hour urine here is 4 liters. So the spot of 35 is actually 140 milliequivalents a day. And so kind of what went on with this patient is that no one reminded the patient that in addition to increasing net negative salt loss, you got to decrease dietary sodium somewhat. And this is a pretty good example of it. My patient is on large doses of loop diuretics and still won't diurese. And so this gets to the definition of diuretic resistance. By the cardiology, or on another day, hepatology's definition, their definition of diuretic resistance is on big doses of diuretics, the patient won't natriuresis. The nephrology definition of diuresis, of resistance, is on the right dose of diuretics, the creatinine increases. And we'll look at that in just a second. And so next test in the patient who won't diurese goes as follows. If I told you the urine sodium was low and the urine potassium was low, as in the untreated heart failure, or perhaps bad heart failure patient, the next test, next drug in would be another more proximally acting diuretic, metolazone, chlorthalidone, hydrochlorothiazide, something like that. If I told you, however, the urine sodium is still low and the urine potassium was big, that means adequate distal delivery, jacked up renin aldosterone system, the next drug in would be spironolactone. So in addition to using the urine sodium to guide you in diuretic therapy, the urine potassium is very helpful as well. If the urine potassium is low, an upstream diuretic. If the urine potassium is high, that's the time to add spironolactone. Questions about this? My patient diureses adequately with the correct urine sodium, but the creatinine increases. That is the renal definition of diuretic resistance. The urine sodium is 65. By honest, I mean that dietary sodium is the same thing. So kind of, but even with the urine sodium is 65, kind of renal 101, the creatinine is gone 13, 15, 17. And so the bottom line here is at this point in time, what you should do is bite the bullet, bite it hard. Renal 101 trumps things again. You got to pee what you eat. And so you got to pee the 60 to 80 milliequivalents of sodium. So charge on, no changes in diuretic therapy. The next thing in may be kind of ultrafiltration, but at least for now, with these levels of sodium, be patient. It is what it is, what it is. And so the last thing you should do is back off. My patient is on large doses of loop diuretics plus metolazone and still won't diurese, i.e. the cardiology definition of diuretic resistance. Why? Next test. Urine sodium is 10. The urine potassium is 10, kind of on maxed out doses of everything. And so at this point in time, and this is where we picked it up last week, at this point in time, this is the time to push very, very hard on the cardiologist to cath the patient If the SVR is high, more afterload reduction. If the SVR is low and you still can't do it, this would be the time you might consider inotropes if they haven't been initiated so far. And so the key here is when you reach the cardiology definition of diuretic resistance, big dose of diuretics, 160 BID of furosemide, 10 of metolazone, chlorthalidone, etc., then before doing anything else, go back and look at the hemodynamics and let the hemodynamics guide you at this point in time. With good diuresis, my patient developed a big metabolic alkalosis. What should I do at this point in time? The sodium is 140, the K is 3.2, the chloride is 85, the bicarbonate is now 45, a big metabolic alkalosis. And so what would you do at this point in time? And I know you know this stuff. And so again, I want to consolidate it. This would be the time that you'd add the acetazolamide. The difficulty from our end with acetazolamide, by putting all that bicarbonate into the urine, the amount of magnesium losses and potassium losses can be impressive, very, very, very arrhythmogenic. So if you are going to start with acetazolamide, be gentle, because it's very effective, as some of the earlier studies have shown, and really potential for mag and potassium depletion are big time. My patient became more hyponatremic. How can I tell if water restriction alone will suffice? And again, I know you know this stuff. This is the time that we're doing the electrolyte-free water clearance. And what I think is that if it's as much as 1 liter a day, when you add insensibles to that, you can probably do it that way. If in fact you're nicer than I am and think that's too much to water restrict, then the role of tolvaptan has been shown nicely to buff or fix the numbers, but doesn't save the life. It doesn't save lives. But if you can make people more comfortable and they can afford it, there's no reason not to use a little bit of tolvaptan. This is an area we're starting to see some SGLT2 inhibitor stuff. I think that's going to help immensely. We've got the SGLT2 data in SIADH. We're starting to see in heart failure as well, and I think that's going to help us immensely. My patient should be very easy to diurese, but is not diuresing despite low sodium intake and big doses of the correct dose of diuretics. What are other causes of diuretic resistance? And so the answer here is meds, 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 and more meds, non-steroidals for sure. But remember, many of these patients are on significant doses of hydralazine. Good news and bad news with hydralazine. The good news is that it improves cardiac index. The bad news is by vasodilating, the baroreceptor may become even less happy. And so it's a push-pull of whether the baroreceptor is going to win out over cardiac output. But be careful when you use this kind of therapy. Last couple of slides on right-sided cardiorenal syndrome. Now, this doesn't even make it in the cardiologist classification of cardiorenal syndrome. From my perspective, this is it's not the most common cause. It's the most under-recognized and understood cause of cardiorenal syndrome. And part of this is because the cardiologists deal with left-sided heart failure, the pulmonary docs deal with right-sided heart failure, and oftentimes they don't talk to each other. either in real life or right side, left sided stuff. And so this goes as follows. This is a 57-year-old woman with a long-standing history of bad COPD and pulmonary hypertension. She has a new right ventricular myocardial infection, a big time. Her physical examination is a blood pressure of 92/58 and tachycardia. Her CVP is 8. Her estimated pulmonary pressures are 70/45, and she's got big time edema that's worse than it used to be. From a lab and imaging perspective, she's got AKI with the urine sodium less than 10. She's got cardiorenal syndrome. Her left ejection fraction is 70% normal. Her right ejection fraction is 15%. This is the kind of person I would be very concerned about if she had new onset ascites, especially if it was tight with regard to intra-abdominal pressures, as something we should talk about, but not today. So next test in and recommended therapy. Well, the next test in, believe it or not, we already have a urine sodium and K. So the next test in is really to do this right heart cath to see what her numbers really look like. And so if her wedge is really 5, the recommended therapy here would be pulmonary afterload reduction, easy for you to say, CPAP, prostacyclin, endothelin receptor antagonist, bosantin, sildenafil, easy for you to say. Not many of these things work effectively in secondary pulmonary hypertension. CPAP is better than the rest, but it doesn't work so well. If that's not doing it, then you would work to increase her right ventricular filling volume to see if you could fill her roadside. You're between a rock and a hard place because the right ventricle is not as compliant as the left ventricle. It may be bulging into the left ventricle. And so this ain't easy. And if you go by stepwise therapy, that is to see if you can do something about the pulmonary afterload reduce kind of first with either CPAP or these agents kind of, and then if not, carefully increase our right ventricular filling volume. Same stem, kind of 57-year-old woman, long history of COPD and pulmonary hypertension. Still has a pulmonary artery pressure of 70/45, but now a CVP of 32, not 6 to 8, and a wedge of 5. So the wedge is still 5, but now the CVP is 32. What would you recommend at this point in time? And this would be the sildenafil attempt, and that if that didn't do anything, then you would very, very, very carefully try to scuff and decrease the right ventricular volume. As I said before, it's more pliable than left. So perhaps by decreasing the right ventricular volume, you'll improve the geometry, left bulging into the left side, and a more effective cardiac output. All right, here are some references. The first references and the third one are David Ellison references from 2019, 2020. The second reference is the cardiology classification and treatment of heart failure and cardiorenal. With all due respect, I don't find that as helpful as the renal ones. And then the last reference came out over the summer in CJATION. It's a renal review of the cardiorenal syndrome. So if I could leave you with a couple points, the real point is the whole idea of diuretic therapy, kind of renal 101, the fact that the sealing effect of diuretics, the kind of rebound effect of diuretics, and that after diuretic therapy, you get less of an effect with each dose. and salt and water retention when the diuretic wears out. Kind of those would be the main concepts that I'd leave you with. All right. Thoughts or questions for me, or something that you'd like to see me go over again and handle differently? All right. Good news is first paper ever that has used the spot urine sodium as a way to kind of monitor the treatment of heart failure. We don't have it yet in liver disease. It's coming. We don't have it yet in nephrotic syndrome. It's coming. But I think that is, as many of you heard me say, one of the basic principles of nephrology. Principle number 1 is to protect the nighttime fellow. Principle number 2, as I said, renal 101. What you eat or get given by the intern, got to come out in the urine. Okay, guys, that's all I got. Have a good afternoon. We'll see you at the party next week, perhaps.
I forgot about that. Yeah, do you have an outfit?
Say again?
Do you have an outfit?
No, do I need an outfit?
I don't know. Kendrick told me that we're supposed to have an outfit, but
Oh,
I
I
didn't
did
know
Christmas
that.
sweaters.
I can't see. You know, kind of, maybe I'll come as Hanukkah Harry.
thank you.
Yeah,
Thank you.
yeah, I'm going to stay around and listen to Marco.
Oh my God. Or I think, was it Trey's
So good.
like shot on the
Yeah.
front, my picture on the
It's
back.
so good. Get better.
You decide to say that?
No.
Did you decide to say that?
No.
I like that we're doing away with that tradition.
Yeah, man.
And make sure.
No disagreements.
Sorry.
Hearing Marco?
How do I do that? Big green.
Your email.
Dr. Linus, can you see?
Yes, I can.
All right. So I'm gonna talk today about the HEMO trial. Let me get this out of the way. So background for HEMO trial, it was to analyze the effect of dose on dialysis and also the level of flux of the dialyzer membrane on mortality and also morbidity among patients that are undergoing maintenance HD. All right, there was another trial many years ago after that also analyzed dosage of hemodialysis prescriptions and found out that there was decreased morbidity with increased dosage of prescriptions. This was a national cooperative dialysis study, and this was sort of like a continuum of it to see if there was any mortality benefits. Plus, also they added the flux membrane variable, and there was also some observational studies after this big trial that showed there was some association between using more high flux membranes, and that could give us decreased mortality, but these were not randomized clinical trials. So on the methods of this study, This was done in 15 clinical centers with 72 participating dialysis units. It was 1,846 patients with two variable randomization. Essentially, it was standard dose dialysis versus high dose dialysis, and with also low flux versus high flux dialysis. And the way we measured the dosing was through the URR or also KT over V. They did both of them. On the methods, they mentioned that the current guidelines recommend a UR of 65 or a single pool KT over V of 1.2, or you can also obtain an equilibrated KT over V to compensate for that rebound urea after dialysis, which usually is 0.15 to 0.20 lower than your single pool KT over V. So it's around 1 to 1.05. In the study, they measure both single pool KT over V using a 2-point urea modeling. Plus, they also accounted for this equilibrated KT over V using the rate of dialysis. The standard dose group was using an equilibrated KT over V of 1.05 or a UR of 60% or a single KT over V of 1.25, and the high dose goal group used a 1.45 equilibrated KT over V or a UR of 75 or a single pool KT over V of 1.65. The way we defined the flux intervention groups, it was done by measuring the beta-2 microglobulin clearance. The low flux group had a mean beta-2 clearance of less than 10 per minute, and the high flux group had a clearance of more than 20 mL per minute, and an ultrafiltration coefficient that was more than 14 mL per hour per milliliter of mercury. Clearance was measured for the beta-2 microglobulin, also intradialytic changes of it. They use multiple flux, low flux, and also high flux dialyzers. I mean, they just mentioned it on the methods over here. They could not substitute cellulosic membranes on the dialyzer, and they can actually reuse dialyzers, but based on the methods and also the clearance profiles of each dialyzer. The way that they enrolled patients in here was 18 to 80 years old, patients that were undergoing at least thrice weekly HD for 3 or more months between March of 1995 and October 2000. Patients essentially their prescriptions were recorded for 3 weeks initially, and then they adjusted to see if the individuals were able to achieve a high dose goal in case they were going to be randomized to the high dose group. Exclusion, where basically individuals could actually cannot exceed 1.5 mL per milliliter of 30 liters of urea, basically meaning that they could not go to the high dose group, that they were less than 2.6 grams of albumin initially, or they cannot achieve also an equilibrated KT over V of more than 1.3 in 4.5 hours. Now, they also excluded morbidly obese patients, so 97% of these patients were less than 100 kgs. They monitor adherence by using urea kinetics every month, and they also measured beta-2 clearance in the high flux group every 2 months and every 6 months in the low flux group. They use this index of coexisting disease to see if the patients acquire any other comorbidities like diabetes or anything else that could make an impact on the patient's mortality. And this actually excluded diabetes. And then they also measured BUN and beta-2 microglobulin before and after dialysis at months 4 and 36. Primary outcomes, as usually, was death of any cause, and the secondary outcomes were hospitalizations that were not related to any vascular access issues. The composite endpoints were either hospitalization due to cardiac causes or death from any cause, hospitalization for infections or death from any cause, or first decline of more than 50% from baseline on your serum albumin level, or death from any cause. Secondary outcomes were death from cardiac causes, infectious causes, a composite of hospitalization for cardiac causes or a composite for hospitalizations for infectious causes. They randomized, as I mentioned, 1,846 patients to around 1.5 years. And if any of these patients in the next 4 years either died, received a kidney transplant, or went to a non-participating dialysis center, they grabbed new patients and randomized them in the final year of the trial. They followed the patients around 1 to 6.5 years, and the power was 84% to detect that 25% reduction in mortality for each intervention. They used a Cox regression analysis for the primary outcomes, and they also stratify based on age, sex, race, years in dialysis, absence or presence of diabetes, or any other comorbid conditions, the albumin levels, and the interaction of albumin with time from randomization or how it changed. They do the two-sided p-values for all the Kaplan-Meier charts or tables, and also they did a similar Cox regression for secondary outcomes and a Poisson regression for the rate of hospitalizations. The first table over here essentially shows the characteristics of all the patients. I did not highlight absolutely anything because they were pretty well randomized. Mean age was around 57 years old for all the groups, standard, high dose, low flux, and high flux. There was a good representation from females, around 56% for all groups, and also of African American, 64 to 61%. 44% to 45% of the patients had diabetes, and many of them actually had cardiac disease. 80 to 81, 78%. Almost all of them underwent at least 3.7 years of dialysis. Weights were around the same, and almost all of them also were hypertensive with the same, almost good means of creatinine levels, total cholesterol levels, and as I mentioned, you need to be normal, a normal albumin level. You cannot have a low albumin level, and the KT over VTs equilibrated were around the same for all groups. All right. Okay. In the second table, they analyzed mortality between all the groups. And essentially, I'm sorry, these were the mean characteristics of the treatments. As you can see, the only differences were between high dose and standard dose groups. They had an increase of blood flow rates. And also they had a higher urea clearance and also a higher equilibrated KT over V. In the low flux group and in the high flux group, there was an increased clearance of beta-2 microglobulin. I'm not surprised about that. And also there was an decreased ratio based on the dialysis session years. So as you can see in the high flux group, they had a much greater clearance of beta-2 microglobulin. All right, so mortality per se. There was no difference in mortality between all the groups. Okay, well, you're already so, but there were actually some mini differences were not actually statistically significant, but were around 4% difference between the high dose group and the low dose group in mortality, and also between high flux membrane and low flux membrane were around 8%. But these were never statistically significant. Other than that, as you can see, the p-values are actually important here. As you age more than 10 years, you have a higher mortality. Black people tend to have less mortality, and also females. Diabetic patients actually tend to have more mortality. And if you have an increased duration of dialysis, you tend to die more. Increased ICED score or more comorbidities, you also have more mortality over here. If you were having an increment or per increment of albumin, you also have more mortality. And the interaction between your initial albumin and also how your albumin changed during treatment, it also had a significant effect over here. And then when we see the Kaplan-Meier curves, there was no significant difference between either the standard dose group or high dose groups versus the low flux and high flux. The other thing they did also, since we had this tiny difference over here in the high flux versus high dose group, they also mentioned that they did a relative risk to see if there was any difference from any other stratifications between infectious causes or cardiac causes, and they did see some differences which were non-statistical. But if you see here, there was actually a less death between the less cardiac causes or less death from cardiac causes or hospitalization in the high flux groups compared to the low flux group. Presumably, if you're dialyzing middle molecules, you're having less cardiac causes. That's about it. I think there was like a commentary like 6 months after this trial that they mentioned that try to say that there was a difference, and that was in the New England Journal of Medicine also, but essentially the conclusion says that there's no major benefit between using a high dialysis dose and also using a more high flux membrane in mortality. And they also mentioned that they got their own KT over Bs, or just to compare to the current guidelines, which are this pretty much. That's about it. Yeah, that would be good. Dr. Linas.
Yes,
Any comments?
I'm not sure what you're asking me. Oh, comments.
Yeah.
It's a classic. And along with the CVVH versus HD and dose of CVVH or CRT, they really have become classics in nephrology. It'll be a long time to any or really repeated or things change. And the problem with all of this is that the renal side of all this is just the tip of the iceberg. Nothing's going to happen from a renal perspective unless whatever the acute event is is reversed, and we're just buying time for the acute event to reverse. And so it's almost like you got to adjust it for the primary outcome that no one has really done yet.
Thank you.